other side is doing a 2-year nursing program where you barely spend time in labor and delivery. So where is that is setting you up for success in the goal? The CPM schools, they're really into how we are going to train you for what you want to do.
Right,
Now we're
exactly.
going to take your money and train you for a plethora of things that you'll never use.
Right.
It's such directed training. I know that when I graduated, I felt so comfortable starting a practice right away. And I had friends who graduated CNM school and they're like, ugh, I got to take another apprenticeship. And I'm like,
And they
then you're
should,
not
because
prepared. Yeah, they should. It doesn't prepare you in the same way.
So one of the things that's really important to this whole conversation is that in 2010, becoming enacted in 2011, a master's degree became the requirement. There was no grandfathering for professionals that were working in New York before the effective date of the law. Even if they were actually working, they could have been working for 25 years, which was actually some of those midwives upstate were doing. And in terms of the cost of education, the financial hardship and burden, so the cheapest way to go right now will cost, if a person qualified for FAFSA, it would cost them $30,000 just for the master's degree segment, because SUNY you can pretty much pay for with FAFSA and TAP. So that basically means that because of that financial hardship and burden, and also the difficulty of recouping that cost if they end up working in rural communities where they're
Mhm.
most needed and where residents usually do not have health insurance, also home births, because the new ACOG recommendations have often shut out insurance coverage. I know Aetna said, we don't cover home births anymore,
well,
period.
they haven't for many years. They haven't for many
Yeah.
years.
I
Yeah.
guess they just needed a like they're just using it as their latest reasoning.
Yep.
Yeah.
But because of that, if this person has a $30,000 debt, it's going to take a lot more consideration beforehand to say, do I really want this debt? Do I really want this 7 years? Um, and in some of those upstate counties that we were talking about before, with a high percentage of Mennonite and Amish people, 88% of people are insured, which means that like 12% of them are not. So how does this kind of fit into this whole conversation?
So can I cover that, Dalit?
Yeah, please.
So in terms of the $30,000, what I would say is that is only for the masters. You're not
Right,
talking
exactly.
about, if a person wants to become a midwife, they have to either be a CNM or a CM. And a few, quite a few of the CNM programs are now DNPs, not just masters. So you're talking about doctors of nurse practice, and there are at least two and maybe more schools that have that requirement for graduation. So there's a real problem right there that entry to practice is now going to be a doctoral degree, and they just keep upping the ante. They have not required that, but there are schools that are using that as they're pushing that as the elite, right? Like
The top tier, yeah,
top tier,
the best of the
right? The
best.
best of the best. So that in itself, you're talking about more than $100,000 by the time you go through undergrad, graduate, postgraduate work, and your certificate as a midwife. It's outrageous. So the average CPM MEEC accredited school, and this is what is going to be what people are going to have to go through, is anywhere from say 10 to that 30. You may have MCU is probably the most expensive one, and they were at 30 like a number of years ago. I think they've raised it a little bit more. Their prices are out of reach. However, that school did apply for section for Title IV. So they do have Title IV. There's only 3 schools in the country for CPMs that have Title IV, and one of them is MCU, another is Bastyr, which is a master's program, and the third, and again, so Bastyr and Southwest Technical College in I'm sorry, Wisconsin.
Wisconsin.
Those 2 schools are actually regionally accredited schools, and they have Title IV also. So you can get the loans, right? You do your FAFSA, you can get your loans, you can get all kinds of things. Um, the vast majority of CPM schools do not have that. It's very hard for the CPM schools themselves to survive. We don't have a broad enough base of, you know, of financial. They're private institutions where, a midwife just wants to pass on the knowledge and decides that they're going to become a school. And that has happened. I mean, there's right now, I think there's only 11 MEEC accredited schools in the country. Is that right, Dalit? Is it 11?
Yeah, I don't know the number, but that sounds right. I do know that more schools are trying to come out. I
Definitely.
just saw another one. And what we're, I think I'm part of a school in Detroit that's trying to also, create a better a more reachable learning environment. And I think that with the popularity of home birth and the um maternal mortality rate in each individual state, are really, we realize what we need to do is get sponsors and scholarships and
Well, and we want MEEC schools. We want more MEEC schools. So the
yeah,
reality is that part of what we're hoping to do in New Jersey, and I imagine the hope would be the same in New York, is that once we have licensure that is inviting, that the MEEC schools will want to do satellites minimally and maybe even start new schools in the states. And that
yeah.
will increase access to the local people who don't have to go all over the country to get their in quotes numbers.
Yeah, because what you said, the schools that you were talking about, right? We have Yale, Downstate, and NYU. Those are very located. They're not anywhere near the areas that we were just talking about for New York. So we're talking
Right.
again about relocating just for school. So
Right.
not only the tuition, not only the debt that you're taking on, but also the relocation fee, whether you have a family, don't have a family, what you have to do. And I also think the whole apprenticeship model, you usually start working in the same town or the same state as your preceptor. And that's almost like another little like, here, let me get you started in the area, and here I am for questions. When you're going to a school all the way, in New York City, and you live in Rochester, New York, and then you're leaving your group, you're leaving your fellow students, you're leaving your preceptor, you don't have that community anymore, or even the hospitals you used to transfer to. And now you're relocating again to start a practice, without anything. It's again, it just creates like a lot of um just inaccessibility for the midwife to start in the same way.
Right. And I actually didn't even mention NYU. NYU is $100,000. So like
Right.
Well, this is what I'm saying. This is what I'm
if
But
you
it's
if you
summing that up,
if
isn't it?
30,000 is difficult, I mean 100,000
Right.
is like it might as well be a million.
No, it might
Exactly.
as well be a million indeed. And so,
Yeah.
like I said, the average, I think the lowest one right now is at around 10 for the program. And then the highest is somewhere between 30 and 40.
Okay.
$10,000 is impossible for some people, but at least it's scholarship accessible. Like there are people that are giving these scholarships. There are different ways that folks can get what they need.
Right.
I mean, we're in desperate need of more Black midwives, of his Spanish speaking midwives, Black midwives. Like we're in desperate need for that. And if it's more accessible, And just, it's not only a high school diploma, it's a high school diploma to get into the school. Then you have all this work that takes you 3 years to do. It's, this is
The
what,
other side is doing a 2-year nursing program where you barely spend time in labor and delivery. So where is that is setting you up for success in the goal? The CPM schools, they're really into how we are going to train you for what you want to do.
right,
Now we're
exactly.
going to take your money and train you for a plethora of things that you'll never use.
Right.
It's such directed training. I know that when I graduated, I felt so comfortable starting a practice right away. And I had friends who graduated CNM school and they're like, ugh, I got to take another apprenticeship. And I'm like,
And they
you're
should.
not prepared. Yeah, they should. It doesn't prepare you in the same way.
I mean,
Right. Yeah, and especially because becoming a nurse in the first place, yeah, you're gonna have to learn how to like needles and you might have to do surgical
Geriatrics
assists and yeah, all of
and
those
nothing
different
to do
things.
with what we're doing. Yeah.
becoming
Right.
a becoming a CPM in the United States of America meets the International Confederation of Midwives standards for school.
Hmm.
So it may not if you're going PEP depending upon the situation, but we're not doing PEP in either New Jersey or New York. Unfortunately, they took or did they end up taking PEP plus Bridge out? I think they had to.
I think it had a deadline and now
Yeah.
it does, and
It
now it's out.
probably had the 2020 deadline like
Yeah.
everything else. Right.
And yeah, because we do want to express that the education is accessible, but I really want to be clear that accessibility doesn't mean less than.
Right.
It
Exactly.
really that is skewed sometimes, and it's really not the case.
It's skewed a
Right.
lot. It's skewed a lot. Don't look at any of those comparison charts. I can send you a more recent comparison. It's like paragraphs instead of a chart. And that was made by the ACNM, NACPM, AABC, Mary Lawler's new think tank, and another like five different organizations got together and wrote a much more equitable, if you will, comparison chart. And it doesn't have any numbers in it. It doesn't have like it says they all have education in what they're doing. Like it's a much I have to find it in my computer. I
Yeah.
only have a like a picture of it. I don't have the actual PDF of it. I can let me see if I
Okay.
While you're looking for that, I want to back up just a little bit. I'm sorry. I'm sure you have an agenda, but obviously we can't stop talking. But just you something that was I thought was really important. Oh shoot, now it's gonna lose my head. But it was a few questions ago about oh boogers. Oh my God, Vicky, what did you just say that made me think about it?
I don't know, I'm talking about compare.
Not being less than the numbers.
Well, we definitely do higher numbers of certain things, right?
Hmm.
They have more pharmaceutical stuff, but they're also doing prescriptive privileges, which we're not. So we do pharmaceuticals for the 12 basic drugs that CPMs are using. Now, we're hoping for expanded practice, and NACPM is talking about expanded practice. Well, when you get expanded practice, you go to school some more. Like nobody's trying to do anything that they're not going to be qualified to do, you
Right.
know?
Yeah, and that actually is one of the things that there's definitely a perception that if you have a master's degree, it's better than the CPM, and that's what the hospital association said that was better, and everybody thinks it's safer, and there's less liability. But like when you actually look in a hospital setting, their numbers are not that great, and that's where a
And
lot of the
if you look
maternal
at
mortalities are happening. Sorry,
And
go
like
ahead.
you said, if you look at the 39 states that have licensed CPM, they have very good numbers.
Right,
It
exactly.
didn't drop things, because of that.
It's
Yeah.
actually it's actually 38 and
Okay.
New York doesn't count. Like everybody wants to count New
Oh,
York. It's
sorry, I remember what it was.
go ahead.
I'm gonna interrupt you. Um, we were talking before about Vicky had mentioned that the I think it's AMCB has the test and didn't want to give the test. Something so important I want to say is that New York um is going against its own law because New York State should have a test. It says in the law that you can test in to practice in New York,
But they
but
have
they
no
were
tests.
using the AMCB test They don't actually have a test, and that's why we can't do it because AMCB said you can only take that test if you go to our schools. So I forgot what the word is, but New York State is in, what is the word, Vicky? It's like illegal. The
It's
New York State
illegal.
is
It's illegal.
something with the letter of the
They're out
law.
of compliance. They're out of
Out
compliance.
of compliance with the letter of the law. I just remember, I'm sorry, that took me a long time, but it was an important piece of why we can no longer test in.
Right. Right, right. And then New York is actually different than most other states, except Pennsylvania and I believe Ohio also, in that it has high populations of Mennonite and Amish people, with significant numbers identifying as Old World, which are the ones that like, so there's some Mennonite and Amish people you would never know that they're Mennonite or Amish. They don't wear the clothes, they don't have the horse and buggy. But there are the ones who do, they don't use electricity, hospital care, washing machines. They wash their clothes by hand. And now they deliver most of their babies at home unattended by an experienced birth provider. So, in cases where the neonate has difficulty breathing, it's likely to take too long for help to arrive by ambulance to assist them without permanent damage or death resulting, where these deaths may not be recorded, so they are invisible. So, statistically, according to the AHA, 1% of neonates will need skilled emergency assistance to breathe, without which they may not survive. The requirement for neonatal CPR training is a regular part of midwifery license requirements, right?
Yes.
So,
Yes.
how do you see that having CPMs could potentially mitigate this problematic issue for
Go
those
ahead, Darlene.
Yeah.
That's obvious, right? That's just obvious.
Yeah, I think you answered it, but basically we are trained in neonatal resuscitation. We redo our training every 2 years. And that means that we can breathe for a baby or restart a baby that needs help until further help comes along. Or a lot of times the first responder for that comes to the home birth in those cases is a transport. They are not trained in the same way. So having a midwife there, even a baby that needs to be transferred, even if we're in New York City and 911 comes in seconds, the midwife usually continues to work on the baby until a higher care provider is there. So having a midwife
Well, not
definitely in
even
the,
there until we get to the hospital.
that's what I mean, until we pass on to a higher care provider. So yes, definitely in the rural setting that would happen. And in the setting where the 911 comes on the quicker side, we're still continuing care, and we are trained to do this kind of work for the baby, and it's different than CPR, and it has like also an experience part of it where, like, we understand the birth of the baby, why this baby might be struggling, can also help us know what to do to get the baby started. It gives us a lot more piece of information because we have the continuity of care as well.
Right. And actually, I did want to mention in Staten Island, I'm going to put the statistics on screen here, but it's actually 16 minutes for the ambulance to arrive. So brain damage happens after 4 minutes in an adult. I'm not sure if it's exactly the same in a neonate, but
I think we say 5, right, Vicky?
that
For
brain
like
for
shoulder
brain damage.
dystocia, we have 5. Yeah.
Yeah, it
So if an
depends on
ambulance takes 16 minutes to get there, and then upstate New York, like I'm sure the numbers are not not as quick as that.
I
Um,
think
So
if
I
I
just
remember
want to
correctly, it
interrupt
could
for
take
a
an
second.
hour.
I just want to tell you guys, Governor Murphy is on WNYC New York NPR radio station right now and is taking calls, our governor. If anybody has the time and inclination to call in to talk about our bill, that would be amazing. So our colleague said I would, except that she's had wine and she doesn't want to call in. Oh,
so I wanted to, you know, the midwives in upstate New York who were prosecuted back in 2019. It appears from the film and from some of the things that we've read about it that they were not pursued legally for the deaths of infants. Like it wasn't like all of a sudden there was a high spike in infant mortality, and that was why they decided to go after everybody. So can you kind of talk about how that whole thing unfolded and why they say it happened, or why, you guys think maybe that it did happen?
So a lot of it is hearsay. There was a particular
Yeah.
officer by the name of Mark, somebody, I think his name was Mark. You'd know from the film, I'm sure. I'm trying to remember, it was a long time ago now, who was absolutely following midwives around. I don't know where he got his instructions from. I don't know what happened. He was a nightmare. So it was a while that Liz was like, something's going on here. And ultimately, they arrested her and charged her with 92 counts or 93 counts, I think it was, that included like 90 of them were about labs, right? And it was just ridiculous.
Text messages for the other midwives.
Text messages,
It was a
exactly.
witch hunt.
There was no question about it. And I think the guy's name was Mark. I wish I could remember his last name now. It's just been a while. I happened to have been called in by her attorney, Michael Sussman, and asked to read the case to just see, like, what did she do wrong? And I read over 400 pages, well over 400 pages of documentation, and she did nothing wrong. She made an appropriate, well, what she did wrong was practice midwifery without a license. So she did do that one thing wrong. And ultimately, I think all but one or maybe two charges were dropped. But in the meantime, there's all this press about 93 charges, and that's what people remember. The baby did die, but that baby didn't die until 8 or 10 hours after she got to the hospital. So the baby died in their care, not in hers.
Was it a congenital anomaly or am I
I don't
misunderstanding that?
remember. I don't remember. I don't think so. I think it may have been meconium aspiration or something. The baby wasn't even, was the baby even born at home? I don't remember. You guys have seen the movie. I didn't even get to see the movie, which made me mad because I was part of this thing, but whatever. So I didn't make me mad. I was sad that I didn't get to see the movie. Um, in terms of the other two that were arrested, which were Melissa Carmen and Lissa. I can't remember her last name.
I also am blinking. It was a Mennonite woman. Yeah, I care.
I also do
Oh,
know
Hornick. Horn.
Hor Hor yeah, Hor something.
Hornick.
H-O-R Hornig. That's it. Lissa Hornig. The reason that Melissa was arrested is because she text messaged Liz about something and offered
Supposedly.
supposedly and offered her something. I saw those text messages. So my name was also in those text messages because as a licensed midwife in New York and as a personal friend of of Melissa, I was hearing some of this goings on. Now, we didn't know these text messages were going to get included. And the text messages between myself and Melissa were used in Liz's trial. Like, what did one thing have to do with another? It was a complete and utter use by this guy who, I don't know, had some kind of vendetta against midwives. And I don't know that they ever found out what that was about.
Yeah. So, yeah, I think it was the prosecutor, or he was like the attorney for the state, or something like that, and just decided that
Yeah.
it was important to make sure there were no midwives in this community. It wasn't like he was like, "There's enough midwives in the hospital," because there wasn't. I think there was like one hospital in the whole county
It
over
also
there.
didn't help that the
No,
CNs in the
I
area,
don't mean to interrupt, but also Well, first of all, they were too far really to serve these fast birthing people, and they had a very high fee. You were talking about this before. We know that those three midwives were offering reasonable for the community fee.
We're talking about like $500 for a course of care. We're talking about they were doing it for free.
Yeah, that's actually something that I was trying to understand because I was like, it doesn't seem like they're charging $5,000 like the birth
No,
center over there that's
No,
in
right.
no,
Yates County, I believe. Because I looked on their website and they
no.
charge $5,000 for a birth. And
I
I was
mean,
like, how is that possible? They probably aren't. But so
they're
if they were
not,
like
and they
charging,
don't
yeah,
advertise those fees, and the three of them had different fees, I'm sure. And I do know that my friend's fee was so low, I don't know how she survived because she was the breadwinner for her family. And she survived because she did 200 births a year. Like, and that's insane.
Yeah.
She's not working
They
in New
keep her
York.
busy.
Like she's not working in New York. She went to Pennsylvania. She has to drive an hour plus from her house to go to this birth center that she opened in Pennsylvania that the Mennonite or Amish folks, it was Mennonites. Like they basically built the birth center for her. She bought the property and the two buildings and they like came in and did their Amish thing and like fixed up the buildings and plumbing and all the rest of it. And she's still working there, but you can't survive that as a midwife. It's so unsustainable. But these women are so devoted to their clientele. So now what's happening is those women from New York State are traveling all the way to Pennsylvania to have their babies if they want a midwife who can actually take care of them.
right.
Or they have to pay $5,000 to the CMs who won't
Who
charge any less.
may not make it because they were not in the driving distance. They were
Right.
Right.
far. And
Right.
they had to go to them for prenatal care. It wasn't affordable, not just in the money sense. It wasn't an affordable replacement for the midwives that they were charging. And I really think, like you said, I don't know what the vendetta was. I don't know if they were trying to make a point of these midwives, like using them as examples. But it just really shows me again and again we live in 2026 and people just still don't care about women, and they just, oh, let's put these people on trial and leave hundreds and hundreds of birthing people without a provider. And it was, and for nothing. The families didn't complain. They didn't have bad outcomes on their head that they could have avoided. Like, it absolutely made no sense at all, and what a disservice to the whole community for nothing.
Social angle is really important because there are a lot of New Yorkers who can afford that, but especially people in upstate New York, they can't really afford a master's degree. And then when you think about like them coming down to the city and
No, it's
uprooting
ridiculous.
their life and everything, whereas if they had the CPM credential, and the whole argument against the CPM credential is it is less safe.
It's so not less safe. It is absolutely not less safe. I mean, look up any of Missy Cheney's work. Look up the rural work. Melissa Cheney there's a study on rural birth. CPMs are safe. So, also don't forget there's a screening process. We're not doing high risk in these areas. There's a prenatal screening process, and right. I think, when people think of it, they think of the worst hospital birth they've been through, and they're like, well, that can't happen at home. But it doesn't. Mm-hmm. And we are really good at handling emergencies. Like, when the emergencies happen, we do it. Like, we just do it. And, well, that's like the difference. Sorry to interrupt, but I just want to say, like, it's not that we think every birth is going to go normal. If that happened, then you don't hire a midwife, you do it yourself. And we're there for the risk that something might come up. But the difference between what comes up with a healthy, low-risk mother and baby or birthing parent and child is different than when you have complicated prenatal stuff going on, and then you're already at a higher risk, and then they have the birth. So that's what I was saying.
Right. And if you were to have like a Mennonite woman who you did the prenatal screening for and it turned out that she did have a high risk birth, you would recommend that she does go and do that in a hospital.
Yeah, and again, it's about choice. So what I would do, especially because we're dealing with a culture, religion that might have different choices than me, is present her back the story. We also forget that women can make decisions for themselves. Here's the information. This is you and your baby. I don't feel comfortable doing this at home anymore. This is where I'm recommending you to go. And your choice in the end is your choice. You know, I think it's like also that same like hospital mentality, like, come in and I'll take care of it and I'll do it and I'll give you something. I'm not going to tell you what it is. I'll give it to you. You don't have to worry about it. You know, and some people really take to that and they don't want the responsibility and they don't want, to take on that thing. But when we do home birth, we have people taking responsibility for the care, the health of them and their baby. You can't just go around and, eat garbage and take drugs and have a home birth.
By the end of care, I've had people actually say to me, please just tell me what to do. And I'm like, no, no, I'm sorry. You're the one who has to make this decision. You are an autonomous, sovereign human being. Like,
yeah. I mean, sometimes I'm like, if you want my opinion, of course I'll share it.
right.
But in the end, the decision is really the person's. And also for us, right? Like, let's say it's a situation we really don't feel comfortable. They still want to stay at home, but I will say, we're transferring care. And then the person does with that what they will. That's free choice. We really forget that we promise people that.
We also develop a relationship with people so that they trust us, so that when we say this is no longer safe at home, they believe us.
Right.
And that's a huge piece of the work that we do. They're not having trust relationships built with their practitioners when they're going 90+%, I can guarantee you, when they're having.
Yeah, they met them for the first time.
Right.
Yeah.
So.
And that it kind of like goes back to the informed consent thing where, hospitals and all of those places are supposed to give people informed consent, but that's the biggest complaint that people have is that they didn't get informed consent. They weren't told what was going to happen or what could happen, or if you take this drug or if you do this procedure, these are the risks. They kind of hide the risks in a lot of instances.
And fear mongering. It's not true informed consent if you share a story of like, well, what I would do if you were my wife or you were my child, that's skewed. You just put a lot of emotion into, something that we need to look at clearly with statistics and choice and etc.
Well, and even the term informed consent is implying consent. Like, it's informed decision making, right? Like, it's informed decision making, informed consent and refusal. At least we have to add some kind of language that gives it back to the person who's making that decision,
Mm-hmm. So
anyway,
if we could talk a little bit about how New Jersey began allowing the CPM credential and home birth midwifery, and what New Jersey's timeline was for bringing that portion of the law to fruition, and what the plans and hopes are for continuing to advance the practice of midwifery, including the laws that the New Jersey organization is lobbying for. So kind of like looking at the landscape of New Jersey and what worked and what kind of how they can be like a template for New York.
So unfortunately, neither one of us was involved in the New Jersey law coming in. So that was Dina, who is not on the call. She was part of the group. She was a student, I think, at the time, or becoming a student at the time of when the New Jersey law came through in 2001. She was one of the first. She was like the fifth midwife that was licensed. So a couple of years ahead of me. And I actually don't know what that process is, what that process was. I do know that the regulations went through the Midwifery Liaison Committee, which is, unfortunately, we are under the Board of Medical Examiners. What we're trying to do right now with our bill is get out from under the Board of Medical Examiners. Best practices show that independent boards are a best practice. Independent midwifery, independent prescribing authority, formularies, all of this stuff are best practices, and that's all over the world, and that's what we're trying to do here. And so We are reintroducing our bill. We just tweaked it a little bit for reintroduction, and that should be getting a bill number hopefully in the next couple of weeks. And we would love to see this bill passed in the early days of the Sherrill administration. We'll see if it happens. We have a few things up our sleeve in terms of strategies, which would be, talking about this 79 maternal child health bills that passed, but then there's no midwifery law that is bringing midwives into the state, so hopefully some of our strategies of conversation builders will work. We don't know why our bill didn't pass this time. It just didn't get the attention it deserved at the end of the session, and there were more things that were more important to them. The easier things, we're going to go through. So I don't know that we have the answer to your question.
Okay.
I think you'd need to maybe call Dina or ask Dina if you could, spend 15 minutes on the phone with her, asking her about the New Jersey, the early New Jersey stuff.
So if we could have kind of a discussion of outcomes for babies and new moms, particularly as it relates to infant mortality rates, maternal mortality, C-sections, other interventions sometimes needed, whether for home, birth center, and hospital births that are attended by CPMs, and how these outcomes differ from other types of midwifery practitioners and from conventional OB-attended hospital outcomes. And if you know how the other forms of midwifery measure up against CPMs, so like the CNM and the CMs, and how their outcomes are different and maybe improved from OBs, but are not, not the same. So if you guys want to talk a little bit about outcomes for moms and new babies with the different kinds of midwives and versus obstetricians.
I think we're also comparing things that aren't. We've already talked about the fact that we take only low risk, right? So even CNMs in the hospital have a much higher risk clientele than we do. So I don't think that we can compare our outcomes and have it be a fair comparison to our midwife colleagues, because they certainly have a higher rate of issues that occur in hospital birth, because we take care of low risk, essentially healthy birthing people. So we do. Go ahead.
Sorry to interrupt, but I would say something more like what we could answer is a little bit of different than practice. So I think it's not so much the different kinds of midwives, it's also the system that they're working in. The hospital is set up as a business, it's a system in its own self. So you could have the most well-intentioned CNM who did all the outside training. She did, all the proper neonatal resuscitation for specifically, a better situation between mother and baby, like keeping the cord intact, things like that. She could have done all of that, and yet she's still working in a system that doesn't allow for things to change. We already knew that keeping the cord intact came down from ACOG, came down from study. Okay, we knew it well before, but let's say it came out by, well-known organizations that it was appropriate to keep it intact, let's say at least 60 seconds, if not 3 minutes. How much longer it is taking for a hospital system to put that into practice it is still not in practice every day in the hospital system. So I think it's more the systems that we're working in. And another example I could give you is they have the tools that they have, and it limits them in a way, in my opinion, especially with birth complications. So let's say a shoulder dystocia.
I was going to say the same thing about shoulder.
Oh, you were? Okay, good. Because I was like, I think that we could just get right into not so much the statistics and this. It's we're in such different systems. So let's compare all of our low risk births. You have a person who's giving birth who is hooked up to a fetal monitor on the right and an IV on the left, and she's in a narrow bed and the baby gets stuck, and she's on her back because that's where they are. The best way is to open up the pelvis and shift the baby into a more oblique position. That is so much easier done when the mother is a person that can move. A moving part, right? If the pelvis moves and we hold the baby, that just resolved itself on its own without getting to the nitty-gritty of shoulder.
They also don't wait. Like a very, very basic thing is the baby's head is born, and you wait for the baby's shoulders to rotate. And you can see that because the baby's head then rotates once the baby's head is out.
But a big
That's not how they're trained. They're trained to get the baby
problem
out.
and why waiting is hard, and I'm jumping in, Vicky.
Go ahead.
Why? Because they're not the pediatrician, right? So they have a baby in the mom is something I can handle. That's OB. Then the baby's out, that's pediatrics. But that half and half, I don't know what to do. My job, get baby out and pass to the warmer. And because they don't treat the item as a unit of a mother still attached to the baby, they're just getting the baby out, they're cutting the cord early because they just don't want to deal with that baby. An OB is successful when they pass a baby that has hopefully a heartbeat to a nurse with an incubator, right? It's not a healthy baby, right? Dr. Stu has a podcast, very good, and he always says a success is a baby in the cot. It doesn't necessarily mean a healthy baby. The baby, like that kind of like disconnect in what's going on. So I think that where we like thrive when we're talking about normal birth is that we have the mother and baby as a unit, and we have the ability to move the mother, and the mother has the ability to speak up for what she's feeling, right? If she can express some of the things that she's feeling, that guides us also. So I think that that's a big piece of it, as opposed to like maybe, who has better statistics, or because we're working in such different systems, but it's how we take the individual situation and how differently
It's how we navigate those situations. Like somebody has a posterior baby. Well, we're putting them in deep knee chest for 40 minutes, followed by 20 minutes backwards on the toilet and giving them pulsatilla, and their baby comes out of that position. But they don't do that at the hospital. Like, they've seen a spinning babies thing. Fine, they've seen a spinning babies thing, but then what about actually implementing those kinds of things? How about letting people move around? And, they don't do it even still.
Is how the mother communicates with you, because after you leave and she's still at home, something might happen that's odd, and she's going to think to call you rather than just be mystified or just lay in the hospital bed pressing the button.
Absolutely.
So we actually kind of covered the costs of the home birth. It's like around $5,000 for a home birth, something like that. And is it covered by Medicaid in New York? I'm sorry.
It is covered by Medicaid in New York. You're talking about 5,000 up in the North Country. It's not 5,000 in New York City, right? Like, it really depends upon where you are. All over the country, the prices range from usually somewhere around $4,000 up to as high as $10,000-$12,000 for a birth, depending upon where you are. So, yeah.
Okay. And in New York and New Jersey, Medicaid and private health insurance, do they cover home births still?
New York has a requirement that private insurance companies, and Medicaid also does cover births. The insurance companies in New York that don't have to cover births are companies that are self-insured. They get away with not doing it, and the ACA also gets away with it because they claim that they're a self-insurance thing. So whatever, that's very annoying. But some ACA, every once in a while you can get one to cover, but not always. In New Jersey, some private insurance covers. Medicaid technically covers if you are a Medicaid provider, but Medicaid pays $800 for global maternity care, so no one can do it.
Okay. And what are your organizations up against in the legal process with the Assembly, Senate, and Governor in New York? And what different routes that you guys are thinking that might be effective, since You have the hospital associations, you have the ACOG, other medical groups. So kind of like the bill in New York that's been stalled for 7 years. Since 2019, I think it was introduced, right? So it's not quite 7 years yet. But what are you guys up against in the Assembly and in the Senate?
Dolly, you'd be better. You were longer in that system than I was.
In the New York, yeah. I did leave early, but I would say when I was still there, a big hiccup was just explaining everything we've been talking about. We were talking to an assembly person, Assemblyman Gottfried, and the lack of understanding of the tools we brought and what we did in our education was so great. I mean, questions like, what if there's a fire in the birth center? And I'm just like, what if there's an emergency in the hospital? But that was like a question. So we had to get the, senators and assembly people first to begin with education. These are not people necessarily in their childbearing years or, female identifying, just.
They were OWMs.
Yes, exactly.
Old white men.
So explaining what is going on, why this is needed, why people would choose something outside of the hospital. That was such a, in my opinion, a waste of time. That was such a hurdle, and we kept going around in circles.
And they acted like they didn't know what we were talking about. I was in on some of those meetings, and then over and over and over again saying the same things. And then, oh, well, I'm a champion for women's health. What?
Yeah. And then, every 5 seconds, it's budget. You don't have a lot of time to work with them. You have a few months. I know now Melissa has been, she goes up to Albany, she's lobbying like crazy. And then the money. We don't have a lobbyist. We're not paying somebody we don't have the money to pay for it. And so the people opposed do, or they're not even opposed, they're of a totally different bill, it's just louder, and so they're like, okay, we're going to pay attention to the loudest person in the room. And we just didn't have that ability, and as grassroots as we were, and the Mennonite community stepped up greatly behind those midwives. They were calling, they were emailing, they were sending postcards. It was amazing to see. But it's not money.
Similarly, in New Jersey, we have the same issues. We're educating people; they don't know who we are. We're lucky in New Jersey that we already have all 3 certifications are licensed, but nobody understands the difference. Then you have to explain it, and why don't CPMs have this, and why do CNMs, and who is a CM anyway? I don't even know who they are, and it goes on and on and on, and we don't get anywhere because we don't have any money. We have no backing. We are working midwives. It's almost impossible.
It's like a third job, and it really does. Lobbyists can focus all their time and attention on. So there's time, there's money, and then I will tell you the truth. Some people forget they get pregnant and they are like, oh my God, we really want Medicaid to cover well, or we really want to have this kind of midwife. And then they get busy with their child. Our clientele is busy parents. So they also don't have the time to work on this bill and fight for it and things like that. So I just think it's just, it's an uphill battle. Yeah.
It is, yeah. And, a lot of one of the things that might help is to kind of, get your guys' voices out there and kind of have people try to understand what you do that are in media, that are in politics, that are instead of having to answer the same questions over and over again, which is just crazy that they, because I never realized before a few years ago that the New York session is only 6 months. They start January 1st and they go home on June, and then they're done until next year.
Yeah.
So you have such a small window of time, and things that aren't in the budget don't actually exist. A law could be passed.
Similar issues. So we just had, so if they start in January, up until like May, they're dealing with the budget. Now, right now, they're dealing with a new legislature because they just had the thing, right? So the first year, you have a little bit of time in the beginning, right? Then they get off, and then you have time from, say, September to December, right? Then the next year, the second year, there's going to be politicking going on because it's only a 2-year session, and people have to get re-voted in. So then you have the budget, and then once you have the budget, they're in lame duck because they're not in lame duck until they get voted out or voted back in. But in the meantime, while they're campaigning, they won't pass anything because they don't want it to skew the voters' thoughts on them. That was told to me by a legislator. And so they don't do anything for that 4-month period. And then once November hits and they've gotten in, then they're in lame duck, and some of them don't give a crap at all because they're out of there. And then the other ones are like, let's get this done in the last 2 weeks of the session. There's no time. So it's no wonder it takes 12 years to get a bill passed.
Yeah.
It's awful, but honestly, I don't have the energy for that.
Right.
And neither do the people of New Jersey.
Yeah. And actually, what I had wanted to ask you about, one thing that I forgot to put on here is the surveys of midwives. Do you guys still do like a midwife survey every year for their outcomes and things of that nature? Because I know there was one back in the 90s or the early 2000s that had been published by the national organization. So I don't know if the local organizations do like formal or informal surveys of their midwives.
So we did in 2020 when we were trying to get whatever you call it, what is it called? The waivers, and we collected data from all the midwives and everybody participated. We haven't done that since then. It's not required by law for us to do that in our state. In New York City, I am co-chair of the New York City Home Birth Stats Committee, and we've been doing it for a couple of years. We're trying to change it up because there was some problems in New York City between the home birth midwives and the hospital midwives. The hospital midwives were saying that the home birth midwives sucked, which wasn't true, and so we did this whole giant thing. And we've been sort of working on that for the past few years, but again, it's not required. The best data you're going to get is going to come from Oregon State University and from the Birthplace Lab in British Columbia. Like, those are going to be the best U.S. stats you're going to find.
And what about the Manistats?
Well, Manistats is the data coming out of Manistats is through those two organizations.
Oh, I see. Okay.
Okay.
Yeah.
So,
Thank you so much. Yeah.
Yep. Thank you so much for this conversation. I think that we really, that our audience will definitely learn a lot, and maybe they can actually share some of your passion as well for moms and helping new moms to have more choices and to have better experiences. Because anybody who knows any moms, you just take a room of moms and you're going to have a lot of negative experiences in the hospital, and you're going to have that one person who's like, I had a home birth.
Exactly.
And it was the most wonderful experience of my life. And, that kind of, those kinds of conversations can help too.
Well, and it's not like it doesn't hurt at home. It hurts at home too,
It hurts, but you're not ignored.
It's not the
pain is not the problem.
Exactly.
The pain is not the problem, it's the situation. Thank you so much, and please reach out if you have more questions, and let us know when this comes out, and we're really excited. Thank you for giving this a voice.
Absolutely.
Take care.
Thank you so much. Have a great night.
You too. Bye.
All right, bye-bye.